Thank you, Professor Dimopoulos. It's really a great honor to be invited here. Sorry I came in late. There was a mistake as to which hotel my colleagues went to find me. I think I was at the right one. But, so in the next, I believe I have 30 minutes, is that right?
Yes, even more.
Even more. Okay, well, maybe.
Take your time.
All right, so what I want to do, I know this is a cardio-oncology conference, and we're talking about transthyretin, which one might argue is not an oncologic state, but of course there's an overlap with light chain amyloid, and I hope that I'm going to show you in the next 30 minutes or so where there can be mistakes that are made and overlaps between both light chain amyloid and TTR amyloid. But the bottom line is that this is a disease that is probably, as I hope to show you, is commoner than people recognize and may be confused with light chain amyloid. I've entitled this From an Obscure and Fatal Disease to a Curable Common Condition because I think that this is what has happened over the last 30 years. And I think it is important to look at the history of TTR amyloidosis in order to really understand where we are today. So 30 years ago, what we recognized was familial amyloidosis as the second most common form of systemic amyloid. The first was AL amyloid, which probably at that time was still referred to as primary amyloidosis. But familial amyloidosis, which had been described in Portugal in the 1950s, was recognized as an autosomal dominant disease. It was certainly considered to be rare, and it was, and still is, or until very recently was, a fatal disease in everybody. But it really wasn't fully understood. It was only in 1978 that what was then called prealbumin and now known as transthyretin was suggested as the precursor protein for this disorder. And it was also known that there were amyloid deposits that were found at post-mortem studies in the heart, but it had not been diagnosed in life, and it was considered a somewhat benign finding of autopsies of the very elderly. We've come a long way over 30 years. Perhaps the most important thing in TTR amyloid in order to develop treatments is the understanding of the molecule as a tetramer, which can break down into monomers. And if these monomers do not fold correctly, if they misfold or are not excreted correctly, they may misfold and form amyloid fibrils. And just like in AL amyloidosis, where the light chain is the precursor protein, the abnormal light chain, there really isn't specifically an abnormality of the TTR molecule, but it is the abnormality is in the chain of excretion and misfolding. So a little bit different from AL, where you have an abnormal light chain. You might argue that, yes, well, if it's a mutant transthyretin in the familial amyloidosis, that it is abnormal, but it functions entirely normally, unlike the abnormal light chain in AL amyloid. Well, over the 30 years, a vast number, well over 100 point mutations have been recognized on this very small molecule. Probably the one furthest along is a substitution, the isoleucine 122 molecule, which is a cause of amyloid cardiomyopathy almost exclusively in patients of African origin. Every now and again we see a Caucasian patient, but when you dig deeply into their history, there is probably somewhere in the history that there may be African ancestry. For example, I have a Caucasian patient who's from the deep south of the United States, where his ancestors had slaves, and one might imagine that this gene entered the pool when there were some extensive friendships between the slaves and the slave owners. The other thing that we have learned is that there is not only a large number of mutations, but that these mutations manifest themselves differently and tend to be relatively true to form. So that at the one end, we have the Portuguese so-called MET30, valine 30 MET substitution, which early in life, in the 20s and 30s, presents as a peripheral neuropathy. And at the other end, as I mentioned, we have the isoleucine 122, which is exclusively a cardiomyopathy. But along the spectrum, you can see there are some that are purely neurologic, some that are purely cardiac, but many that manifest as both of these disorders. And perhaps to some extent, the most interesting is the fact that if you escape the neuropathy of the MET30 early in life, you may present at age 50 with a cardiomyopathy due to the same mutation. We don't really understand why some people get neuropathy early in life, some people wait till later life and get cardiomyopathy. But both the neuropathy and the cardiomyopathy in these conditions is due to deposition of amyloid derived from transthyretin. Now, a huge step forward, I don't know if I can go backwards, let me see, a huge step backwards, that's forwards, there we go. 1 second, I'm giving my whole talk in 2 seconds, let me just see if I can, I'm sorry, how do I get back to the slide I was at? Wait a second, might be able to do it on here. I got it. Yeah, I seem to have, there we go. So it was recognized in the late 80s, early 90s, that since, when we were dealing with mutant transthyretin, that since this mutant transthyretin was derived from the liver, that if one could transplant the liver from a patient with this disease, take it out and put in a new liver, that you might stop the disease. It's a very, very early form of gene therapy. And this is the earliest account of this from the group in Scandinavia, along with some patients who had come from the United Kingdom. And that was thought to be a great step forward. Not only was it a step forward for patients with familial amyloid polyneuropathy, that you could potentially stop the disease by stop the production of the abnormal protein by giving them a liver that only had wild type or normal transthyretin. But it was actually a step forward for those patients who needed a liver transplant, who had nothing at all to do with amyloidosis, but were desperate, for example, someone with a hepatoma who might not have been a very good recipient because these livers were subsequently taken out of the patient with amyloidosis and transplanted again into other patients with, for example, hepatoma. So you got two for the price of one in one way. It was great for a liver transplant surgeon, taking out a liver that was functioning normally, putting in a liver that didn't have the gene, not throwing away the first liver, giving it to somebody else, or even cutting it into two and giving it to two donors. So that was a very important issue. Now you might think, why do that? Well, the thought process was, we know that this liver is producing an abnormal protein, but we also believe that it's taken 40 or 50 years to produce a neuropathy in this patient. So we'll give it to somebody else who's going to die within a year, and they'll take 40 or 50 years to get a neuropathy, or they'll be dead without it in a year. It was wrong thinking, unfortunately. So there are a couple of things that occurred here. Number one, the initial enthusiasm for this treatment was tempered by the fact that indeed early neuropathy seemed to stabilize And as I said, the structurally normal explanted liver was used as a donor. But when you came to cardiomyopathy, which I've shown you, that many of these patients had, unfortunately, the cardiomyopathy seemed to progress. And this is work from Simon Dubray when he was with us in Boston back in 1997. Simon noted that if we looked serially at patients who had started off, this line represents normal wall thickness on an echocardiogram. If you started off with patients who had an amyloid cardiomyopathy, who had had a liver transplant, the earliest point where their transplant would be here. Or actually, this is the liver transplant. This is the earliest. Not only did they progress before the liver transplant, but they continued to progress after it. And this was the recognition that transplantation might help the neuropathy, but wasn't helping the cardiomyopathy, and may even have been accelerating the cardiomyopathy. And that made us think. You have to figure, why could that be? Well, as an autosomal dominant disease, this is a disease in which you have one gene producing the mutant protein, and most patients, unless they're homozygous, have one gene producing wild type or normal transthyretin. And this, I think, made us think then that what must be happening, and was subsequently showed by endomyocardial biopsy, that the process of progression of cardiomyopathy following liver transplantation in patients in whom we believe their cardiomyopathy was due to mutant transthyretin and should stop, must be due to wild-type TTR, and there must be some form of seeding, some form of catalytic reaction where the transthyretin that is sitting there already, as it were, brings in the wild-type TTR produced by the new liver. In other words, we have produced a wild-type TTR cardiomyopathy superimposed on a mutant TTR cardiomyopathy, and that the critical point was that there was amyloid in there first, which then takes us, now why would not one get a progressive neuropathy for the same reason? Because the disease of wild-type transthyretin cardiomyopathy is not associated with neuropathy. Wild-type transthyretin doesn't cause a neuropathy, mutant transthyretin does. And so what we were seeing was we had produced a new form of disease. Not only had we produced a new form of cardiomyopathy due to wild-type TTR, but within 3, 4, or 5 years of those recipients who received the liver from the familial amyloid polyneuropathy patient, they were now beginning to develop neuropathy. And it wasn't 20 or 30 years or 40 years. It was 3 or 4, and the shortest I've seen is the development of a severe neuropathy and cardiomyopathy in a liver transplant recipient receiving a liver from somebody who carried this gene. So we are actually producing a genetic disease in patients who are not genetic carriers by giving them this liver. Why did it take such a short time when the other patients took decades? Well, the question is, why does it take decades? And the answer seems to be in the milieu, in the body, something is happening. And that something may be aging, that something may be a number of factors. But once that liver is producing an unstable protein, it doesn't go back 20 years. It continues producing it, and it will give the same disease to the recipient. So that's been a new disease that we have created. So wild-type TTR, let's think about that for a moment. Again, going back to 1987, is this seminal paper from the Mayo Clinic in which wild-type TTR, then known as senile cardiac amyloid, because it was found at autopsy, was pointed out to be a frequent post-mortem finding in patients over 80 and generally regarded as non-specific and no functional importance. These authors went through well over 1,000 biopsies that they had done on their amyloid patients at the Mayo Clinic and came up with only five patients whom they finally determined had wild-type TTR amyloid in the heart, and concluded that this disease, cardiac involvement by senile systemic amyloid, is an important, although uncommon, cause of cardiovascular mortality. And that sat around for 20 years, that senile amyloid, as we would then call it, is a rare, rare disease, even among centers who are seeing a lot of cardiac and generalized systemic amyloid. We wrote a paper in around 2004 in which we looked for senile amyloid and found 19 cases out of 2,000 cases of cardiac amyloid. And we only found 19. Things have changed an awful lot, and it shows you that, in fact, if you look for something, you may find it more commonly. And what I'm going to show you in the rest of the talk is that this disease, far from being the rarest form of amyloid, is probably not only the commonest form of amyloid, but may be a common cause of heart disease in general. So in order to think about it, or rather, in order to diagnose it, you have to think about it, and once you've thought about it, you have to diagnose it. So the approaches to diagnosis, there are three main imaging diagnoses, but we should never forget clinical examination for the cardiologists among us. Here is a neck, and on inspiration, you can see the vein going up, the jugular going up, and once again he breathes in. Jugular venous pressure goes up, which is, of course, Kussmaul's sign. So really, you've only got a couple of things. If your patient comes with heart failure and Kussmaul's sign, he's either got restrictive cardiomyopathy or he has got constrictive pericarditis. And this is quite a common finding in the majority of cases with cardiac amyloid. So that might be an initial suspicion. Unfortunately, clinical examination in the United States is not as good as it should be. I'm sure it's better here in Europe. But then one goes to echocardiography, and here is a typical example, a little bit off axis, but a typical example of cardiac amyloid showing increased wall thickness. This is not left ventricular hypertrophy. Left ventricular hypertrophy is a pathological statement. We in the echocardiography lab can only talk about wall thickness. If we call it hypertrophy, we're right 99% of the time. We're wrong in the 1% of patients with amyloid where it's an infiltration. And if you think of it and only call it hypertrophy, you won't think of infiltration. So I never report my amyloid echoes as left ventricular hypertrophy, only as increased wall thickness. Now, I may be right, and I may be wrong in certain circumstances, as I will show you. Over the last decade, the addition of what is called strain imaging has become extremely helpful. The amyloid heart contracts, or the normal heart contracts not only side to side, as you see here, but longitudinally along its long axis. And that longitudinal contraction, known as longitudinal strain, is significantly impaired in amyloid, predominantly here towards the base of the heart, and relatively well preserved at the apex. Normally, all of these segments contract about the same. In amyloid, the base is much worse than the apex, and it gives you, you can look at the three apical views here and put together all the segments, and those in the middle represent, this is what's called a strain map, represent, red is better here, that's not a political statement, but red is a greater strain. It should all be red, and the further you get out, the further you are towards the base. And that's a typical, thank you, that's a typical appearance of amyloid cardiomyopathy, not seen very much in other types of disease. Now, MRI has become an extremely helpful tool. MRI and amyloidosis, this is a pretty normal, this is taken from the group in London. This is a pretty normal cardiac MRI. You will see that the blood looks gray, that the walls of the heart look black. And here, they are calculating extracellular volume. So the heart is not just made up of myocytes. Some 20 to 25% of the heart is an extracellular matrix. And here it's top normal or slightly thickened in a patient who's a carrier of TTR amyloid, I believe. As one progresses in amyloidosis, you see thickening of the walls, and with delayed gadolinium enhancement, the white here is the gadolinium taken up by the amyloid. And you see you lose the contrast between the blood pool and the wall. This is called, referred to as difficulty in nulling the myocardium. And when you calculate extracellular volume, it's greater. And maximally, once the whole wall has got this transmural delayed gadolinium enhancement, so the wall is white and the blood pool is black, just the opposite here, there is a vast increase in extracellular volume, and that represents amyloid. However, what is rather interesting is that in cases with TTR amyloid, as opposed to AL amyloid, you get some degree of left ventricular hypertrophy. So the ventricle can compensate in a different way than it does in AL. Those of you who've looked after AL amyloid with cardiac disease will know how rapidly these patients progress with a survival of less than 6 months from heart failure unless you can switch off the plasma cell dyscrasia. So in switching off the plasma cell dyscrasia, you're getting rid of light chain toxicity, and you are allowing the heart to stabilize. But on top of that, these patients in AL amyloid have just amyloid infiltration of the heart with a superimposed toxicity, whereas the TTR amyloid patients have a lot of infiltration, but perhaps another 12 to 15% increase in true LV mass, which is a partial compensation for that. And so maybe that's why they do so much better with a survival untreated of 7 years instead of 7 months. So there is some degree of left ventricular hypertrophy, but the vast majority of this thickening is amyloid infiltration. And when you look at extracellular volume as a marker of survival, you can see that those with a markedly increased extracellular volume in TTR amyloid do very poorly compared to those with a lesser degree. So once again, as is the case with AL amyloidosis, this is telling us the earlier you can intervene on the disease, the more likely you are to have long-term survival. The third important imaging agent in TTR amyloid, I would say both in TTR and AL amyloid, is the use of bone scanning agents. In Europe, DPD, in United States, pyrophosphate, PYP. And many, many years ago, when I was first starting in this field, we published some data on PYP scanning in amyloid and found that it was taken up in the heart, but it was not consistent, and we sort of put it on one side as being an inconsistent finding. It was only a decade ago that Claudio Rapezzi in Italy pointed out that the uptake of one or other of these isotopes in the heart, and there should be none, but here you see there is a lot, more intense than the ribs in this whole body scan, is only taken up, or to all intents and purposes, only taken up in the heart in patients with transthyretin amyloid, and it is not taken up in AL amyloid. Very rare cases of AL amyloid where you have a little bit of uptake. So now we have an imaging agent that can distinguish between, to a large degree, between AL amyloid in the heart and TTR amyloid in the heart. You don't get that distinction from MRI. MRI is very helpful because the appearance is rather typical. When you see those appearances, there's very little else other than cardiac amyloid. Echocardiography is helpful, but there are other things that give that picture. So you've gone from a somewhat non-specific echo test that should really raise amyloid in your thought process to MRI, which says, yes, this is almost certainly cardiac amyloidosis, to now a test, once you think of that cardiac amyloidosis, it's telling you it's much more likely to be TTR if you see the uptake than it is AL when there is no uptake. And we published a consensus paper, 2016, in Circulation. I won't go through this, but essentially it looks at a way of determining when you suspect amyloid what type of amyloid you have. I put this up because I often get the question, once you suspect this, is it best to do an MRI, cardiac MRI, or is it best to use DPD or PYP? And I would argue, as we did in this consensus, that you're probably better off to start with pyrophosphate scanning. Of course, you've got to do the blood work. You've got to look for monoclonal gammopathy and so on and so forth. But if you start with this and it's positive, you're going to go down the pyrophosphate path. You may want to do an MRI or not. If you start with an MRI, you don't know which one you're going to go down. You eventually are going to go down this pathway. Now, how important is it to do this scan? It is important because when we looked at the pooled data from several centers using imaging, patients who had cardiac biopsies, it became apparent that in the absence of a monoclonal gammopathy, in the presence of a positive scan and an appearance that looked like amyloid on echo, you are close to 99% certain that you have cardiac amyloid and no longer need to do a cardiac biopsy or any biopsy. And the Food and Drug Administration, which is very conservative in the United States, has actually agreed that a positive scan in the setting of a typical echo is acceptable, and in the absence of a plasma cell dyscrasia, is acceptable for clinical trials that are recruiting patients with TTR amyloid. So we've now got rid of the need for cardiac biopsy with this scan. So I don't know how familiar you are in Greece with the cartoon character Popeye. Was he popular here? But I'm going to argue that Popeye might have had early TTR amyloid. Now, what is the logic behind this? Well, Popeye is well known not only for his spinach, but for his muscles. But there's something that mimics the Popeye muscle, and that is a ruptured biceps tendon. As we mentioned earlier, this is not just cardiac TTR amyloid is not localized disease, but it is systemic. Most classically, carpal tunnel syndrome. 40% of patients have a history of carpal tunnel syndrome. But we recently looked at 120 or so consecutive patients with wild-type TTR amyloid and found a prevalence of ruptured biceps tendon, shown here, of 1 in 3. The population percentage is 8 per 100,000. So now we have a very simple test. You take the patient's arm, gentle pressure against it. If the biceps pops up, that's a ruptured biceps tendon. If they've got congestive heart failure, and if they happen to have a Kussmaul sign, you don't even need an echo transducer. You've got a diagnosis of almost certainly of TTR amyloid, particularly if the echo looks typical. So you certainly should consider it. So physical examination is not dead, and this is due to amyloid in the tendon and may precede the development of heart failure by a number of years. And there are now, certainly in terms of carpal tunnel syndrome, which is the same thing, this deposition in ligaments. If you look at patients who have bilateral carpal tunnel syndrome, as a study is ongoing at the Cleveland Clinic, you will find, and then you stain that for amyloid deposition. A significant proportion will have amyloid deposition in that over the age of 50. And if you work up those patients, a smaller but real proportion will actually have systemic disease. So how common is TTR cardiac amyloidosis? Are we missing it? Well, the first thing one can look at is autopsies. And this is an intriguing paper from the Mayo Clinic. It suffers from being a retrospective study and an autopsy study, but it does raise some intriguing issues. And the authors looked at autopsies from their huge database at the Mayo Clinic and looked at the history of those patients and asked, was there evidence of heart failure with preserved ejection fraction in these patients before they died? And if so, was there evidence of amyloid in the heart? And in fact, the older you get, starting in the 70s, 80s, and 90s, you will see that at each of these decades, there is increasing amount of amyloid, almost exclusively TTR amyloid in the heart, which we've known for many years, that is associated with aging, but that those patients who carried a pre-mortem diagnosis of heart failure with preserved ejection fraction were much more likely to have amyloid in their heart than those without. And in most cases, it was not diagnosed pre-mortem, even though they may have had an echocardiogram. Now, this is the Mayo Clinic. The Mayo Clinic knows how to look for amyloid. So one pre-mortem. So one possibility is the echocardiographer missed it. The other possibility is that the disease actually may not always look like the classic appearance. And could it be that amyloid deposition, wild-type amyloid deposition in the heart of patients in their 70s and 80s and maybe 90s is contributing to heart failure without causing marked thickening of the walls, such as you see on echo? Well, another intriguing small study recently published out of Spain thought about this concept and used imaging, DPD imaging. They looked at heart failure coming into a general hospital with an ejection fraction of at least 50%, a wall thickness 1 millimeter or greater than the upper limit of normal, which is not very much in an older population. And of 120 patients who agreed to undergo scintigraphy, 13% of them had a positive pyrophosphate scan, a positive DPD scan. So 13% of patients presenting with heart failure and preserved ejection fraction with a little bit of wall thickening in this hospital turned out to have a scan suspicious of amyloid. No mutations were found. Only 4 patients agreed to undergo endomyocardial biopsy, but all 4 of those had amyloid. So it could be that 10% or more of patients with diastolic dysfunction and slight or more than slight thickening of the walls of the heart actually have amyloid as the cause. It may not be the typical appearance. They may have some hypertension as well. They may have some coronary disease as well. It could be a second hit, a second factor that is responsible for the, quote, epidemic of heart failure with diastolic dysfunction. One of my colleagues in London has looked at a similar population among patients of African origin presenting to their heart failure clinic, and has found that at least 12% of patients presenting with heart failure of African origin had cardiac amyloid as the cause, almost exclusively due to the isoleucine 122 mutation. So that's in that population, it was the 4th commonest cause of heart failure. And he only looked at patients who had typical echoes for cardiac amyloid. So maybe missed some of the others. And it turns out that if you go back and look at the BEST trial, which was a trial of a beta blocker in heart failure done some 20 years ago, which excluded patients with typical cardiac amyloid, it's systolic dysfunction, and those patients, the African-American patients, were genotyped. 4% of the African-American population, or the Afro-Caribbean population, carry this mutation in the United States. So if you have the disease as cause of heart failure and you go into a heart failure trial and it excludes the disease, you should see less than 4%. It was close to 10% of patients in BEST were gene positive, even after excluding typical amyloid. So this disease, this mutation in that population, increases the risk of heart failure, even if you don't have a typical echo. So what about therapy? For many years, we had nothing, just diuretics. Then we had liver transplantation for neuropathy, but nothing for cardiomyopathy. In the last 5 years, we have come enormously far. And part of it is due to the understanding of this small molecule, this tetramer, which breaks down, as I've said, to the monomers and gives you the amyloid fibrils. And also to the genius of Jeff Kelly, a biochemist in California, who came up with the idea that if we could stabilize the tetramer, then this whole cascade would stop. Initially, diflunisal, a non-steroidal analgesic, was found to stabilize TTR, and in vitro experiments to stop amyloidogenesis. And this was also shown in a trial of neuropathy to slow the neuropathy in patients with familial amyloid neuropathy. Tafamidis was a drug that was synthesized by Professor Kelly and has been around now for about a decade, is available, as you probably know, here, but not in the US, for familial amyloid polyneuropathy, but not for cardiomyopathy. This is a retrospective look at the use of stabilizers. A few patients on tafamidis, more on diflunisal, looking at survival. These have all got cardiac disease. And you can see there is a better survival on stabilizers than not. But it is retrospective, and most of these patients were pretty well, because if you give diflunisal, which the majority of them got, to patients with heart failure, you will worsen the heart failure in some people. It's a non-steroidal, and you will worsen renal function. So you can just make the argument here that what you're seeing is selection of patients. There's less sick patients got on the stabilizer. Those who couldn't get on the stabilizer were sicker and died. But the definitive study comes from the tafamidis study, which was started several years ago, in which patients on tafamidis, a drug that does not have non-steroidal effects, randomized to 20, 80 milligrams, 20 milligrams, 80 milligrams, or placebo, and follow up for 30 months. And Pfizer, the sponsors of this trial, just last month came out with the statement that this has met its primary endpoint, which is a dramatic primary endpoint, a reduction by 50% of survival at 30 months, or a decrease in hospitalizations, reduction is 30% of mortality, or decrease in hospitalizations. The full data, I think, are going to be presented later this year. So that's the first stabilizer that will work, or potentially work, and we should see that now for cardiomyopathy. Even more dramatic are the silencers, either the small interfering RNA or the antisense oligonucleotides, which essentially switch off the production of TTR. We don't really need TTR, apparently. There are other ways of transporting thyroid hormone and vitamin A, which is what it does. And all of these both of these can switch off the drugs, and the trials in neuropathy, which were presented last November in the European amyloid meetings, show that patients on placebo had progression of neuropathy. This is a neuropathy trial. Both drugs, and those getting the silencer had minimal or no progression. So for the first time, we can switch off the neuropathy with these drugs, which will be available within the year. Let me just finish off with another concept, and that is, what if it's too late, or is it ever too late to get rid of amyloid? Well, AL amyloid will regress when you treat the patients in at least 50% of patients in the heart and higher in other organs. But TTR amyloid is much less likely to do so. This, I think, is a brilliant invention by Professor Pepys in London. He came up with a drug not targeting the precursor protein, but targeting a protein that sits on all kinds of amyloid fibrils, whether it's AL, TTR, AA, and that's this inflammatory protein in the blood, serum amyloid P. It binds to amyloid fibrils, and his concept was that this is what is preventing the body breaking down the fibril, this coating of SAP. And so he came up with a drug which depleted the body of SAP, and in mice showed regression of the amyloid. When it was given to humans, it didn't work. So I think that the genius here was not just coming up with the chemical, but going the next step and saying, okay, why doesn't it work? It probably doesn't work because you deplete all the SAP from the blood, but you still leave some stuck to the fibrils. So he went on, having cleared the serum with this drug of the SAP, to then develop an antibody which was given, and the only SAP that is left is on the amyloid fibril. And when he did that, in this New England Journal paper, there was dramatic resolution in this case of a patient with huge amount of amyloid in the liver. And some 6 weeks later, the liver is virtually invisible on this SAP scan and was also had shrunk way down, the amyloid having disappeared from the liver. We are now moving to a study of this combination in patients with cardiac amyloid. We're looking at TTR amyloid initially. We're just moving to AL amyloid in remission. And if we can show that we can get it into the heart and get the right dose to get it into the heart, we may actually be able to remove the amyloid that's already there while tackling the production of the amyloid with these other drugs that I've shown you. Briefly, I want to point out that it's not just in diastolic dysfunction, but in aortic stenosis, there is something called low-flow, low-gradient aortic stenosis, which is characterized by thick left ventricle with a small cavity and a restrictive physiology. That sounds very much like the heart in cardiac amyloid. And it is now apparent that a proportion of these patients have not only aortic stenosis, this is the velocity here, but they also have amyloid infiltration with TTR amyloid, shown in this case here, who has got the combination. And those patients with low-flow, low-gradient aortic stenosis, probably 10% of them, so they represent 20% of the total, may actually have TTR amyloid. Finally, back to hematology oncology, because it's a hematology oncology conference, and I want to just finish with a case that I saw 6 months ago. 64-year-old man who had neuropathy and congestive heart failure. He was seen at an outside center. He had amyloid deposits on a fat pad biopsy with a lambda monoclonal gammopathy in the serum, and his free light chains were said to be elevated. A diagnosis of AL was made, CyBOR-D was initiated, and he came to me having got rid of his gammopathy in the serum, but feeling a lot worse and now pretty much wheelchair bound. Reviewing the chart showed a couple of things. First of all, the free light chains were not elevated. They'd actually looked at urine light chains and the serum were normal, and they thought they got it wrong on that point. And the question really was, should anything else have been done? Well, the story was awfully suspicious that something else was going on here. We did a pyrophosphate scan. Here's a planar and a SPECT scan that should be negative in AL. It is strongly positive. He was genotyped. He had the ALA60 mutation. And what should have been done was that the specimen was sent for mass spectrometry and confirmed that he had mutant TTR amyloid with an unrelated monoclonal gammopathy. So is that a rarity or is it not? Amyloid typing is absolutely critical when you have this combination. This tells you how common this is. This is 123 patients that we looked at consecutively with wild-type TTR amyloid. It's actually higher. If you consider light chain muggers, this number goes up to 23% of our patients with TTR amyloid have a monoclonal gammopathy or an abnormal free light chain ratio. Of those who have the monoclonal gammopathy, about 40% have it. So it's a common finding, commoner than you'd anticipate. We don't know why. We don't understand why, but there seems to be some link there. So therefore, the importance of amyloid typing would be Congo red staining will determine the presence of amyloid, but not the type of amyloid. Immunohistochemistry is helpful, but if you have a circulating paraprotein, it's sticky, and you may end up getting a false positive for lambda or kappa, whereas it's an innocent bystander. Therefore, if any doubt as to the precise diagnosis, you have to do mass spectrometry. Otherwise, this situation will be repeated. So can we play the last rites for a once fatal disease? Yes or no? I think we can, but there are still unexpected surprises to come. You never know what you see if you look hard enough. Thank you very much, and I'm sorry for going over.
Well, thank you very much for your excellent presentation. Are there any questions from the audience, please? Yes, Professor Kastridis.
Thank you very much, Professor. That was excellent. We really wait for something with efficacy in TTR amyloidosis, and the data about tafamidis are really encouraging. I don't know the details. I only know they are positive. But these are data on patients with mutated TTR in tafamidis.
No, it was both wild type and mutated. It's probably, I think, 70 or 80% are wild type TTR. This is the first study that has actually looked at wild type TTR as well.
So this means that this drug will be approved also for patients with wild type TTR
Absolutely,
amyloidosis.
yes.
Okay.
Yes.
Thank you. Thank you.
Okay, yes, please.
Thank you for Professor Falk for your excellent presentation. I'm just wondering, do you think that the ATTR amyloidosis is a genetic dependent disease? I mean that there are several phenotypes in the disease, and I'm just wondering, sometimes we see, let's say, mostly the interventricular septum affected. In other types, we see, let's say, the posterior wall, let's say, affected. So, do you think it's this? I mean, it's a, let's say, constellation, let's say, of different phenotyping, or it's just one phenotype, let's say, with different, let's say, probably penetrance?
I'm sorry, are you referring to the wild type or the? I mean, I don't think we really understand why is it that some patients get wild. First question is really, why do some patients get wild type TTR and in the heart and others not to that degree? We don't know. There's got to be something going on in the rest of the body that leads to that. Since it appears that there are no obvious mutations or abnormalities in the transthyretin molecule that we've found so far in the wild-type patients, I think that the phenotype in the heart is potentially random, but we don't know. In terms of, is there something else going on, there's a fascinating story of a Japanese investigator a decade ago who has a mouse model of TTR amyloid. And he was doing some wonderful work on that, and they gave him a new lab at the university, and he moved his lab, and all of a sudden, the transgenic mouse was no longer producing amyloid. Going back to the old lab, it was producing amyloid again. And it turned out that when he started feeding it with the dirty food in the rundown lab from the previous, that it was producing amyloid. So there is something in the gut biome that can do it in an animal model. So we don't even know what's causing it, let alone what's causing the phenotypic differences in the wild type. In the mutant TTR, again, it's not clear either why it's more cardiac, more neuropathic, and so forth. Well, we'll see, I hope, in the next decade.
Okay, Professor Ι.Παρασκευαΐδης.
Well, fantastic journey throughout the years. Now, there has been evidence that amyloid deposition in the brain is probably one of the leading causes of Alzheimer's disease. Do you think, is there any connection between Alzheimer's and amyloid deposition in the heart, or are they completely different proteins or mutations?
Well, they're completely different proteins. There's no doubt about it. Patients with wild type and mutant TTR, the vast majority of mutant TTR, it does not get into the brain. The brain produces some TTR in the choroid plexus. There are some now late patients who have had liver transplants who get cerebral bleeds, but they don't get dementia. So it is a different protein. But the misfolding is obviously common pathways. But currently, the Alzheimer's group and the amyloid groups tend not to talk, although recently I've started talking with them. But the bottom line is you don't get dementia from any form of the systemic amyloidoses, and Alzheimer's is a very specific form.
Well, we have one more question, please, and then just a second, please. Yes.
Thank you, Professor Falk. We enjoyed your brilliant talk, actually. Is there an early or a specific biomarker that may predict the outcome of the patients regarding their congestive heart failure? I mean, is there a marker that may predict an accelerated process or an accelerated worsening or some milder forms? And the second question, a rather naive question, is there a role of external factors? I mean, is there a role for the epigenetic for the development of different history of the patient?
In terms of the first question, there's actually been a couple of papers published in the last couple of years, one from the group at the Mayo Clinic looking at biomarkers once the diagnosis of TTR amyloid has been made using NT-proBNP and troponin, just as it is in AL amyloid, and showing there are cutoffs. The second paper came from London looking at glomerular filtration rate and proBNP. But both of those were dichotomous variables. Above this, you did worse. Below that, you did better. I'm not terribly happy with these. We're trying now to use machine learning where you can put in multiple variables. And I'm a little behind on this, but I've spoken to a number of my colleagues in the field that we want to put together a database where everything that you get on a patient you can put in. So eventually you can go to a website, put in 5 or 6 things, and it will tell you what the likely prognosis is. Is there a specific amyloid marker? No. But NT-proBNP is helpful. It's not due to stretch of the muscle as it is in other diseases. It's due to compression, or predominantly compression, both in AL and TTR, compression of the myocytes by the amyloid. So that certainly has a specific amyloid prognosis. The second question, well, I don't know about the epigenetics. The mouse model suggests, yes, there are other things, or at least epiphenomena, but they're almost certainly epigenetics. But what we don't see very often is wild-type TTR in twins. I don't think there's been a case. I've seen 2 cases of brothers who have had it, but if it's a common condition, I've seen many hundreds of cases, it might be coincidental. But we have not seen the same human environment in twins, both developing TTR amyloid. And there have even been one case of twins with mutant TTR, one of whom has the most severe form, and the other has very, very mild form, identical twins. So there's something outside of the genetics as well.
Well, thank you very much, Professor Falk. Και τώρα να συνεχίσουμε το υπόλοιπο. Το ένα παραμένει. Όχι, εμένα βγάλε. Ο Πρίτανης και ο Δεχόν.